Thank you. This will dovetail into Dr. Mirsky's talk very well, because I think a lot of the confusion we have with knees and meniscus tears and arthritis is about the gray zone that most of us are in. So I don't see a lot of 18-year-olds here, but 18-year-olds don't have a gray zone. They have no knee arthritis. So this decision-making is simple. When you get a mix of arthritic knee and meniscal tear, what's the right decision as far as your knee, and what are your choices? And that's really what I'm going to go through a little more. So I'm going to sort of take a portion of Dr. Mirsky's talk. I'm not going to talk about knee replacement since he already did that. I'm going to talk more about what's the decision-making with the most common thing we see in the knee, which is a meniscus tear. And when is it important that you have one? And when is it important possibility to have a knee arthroscopy with reasonable success? And when is it not? And when do you need to sort of go toward the knee replacement option? So I don't know how, I didn't get to Dr. Mirsky's at the beginning of his talk, but I'm going to go through some basic anatomy. This is a very busy slide, and I'm going to go to an easier slide to understand. But these are all the muscles that surround the knee. This is a front view, hips up here, foot is down below. This is inside and outside, and that's the kneecap in the front. Now we're going to look, I'm going to sort of really look at the meniscus again, so I want to go through what it is and where it is and what the issues are. So this is a bony anatomy of the knee. Again, hip, foot to orient you, inside and outside. So we have ligaments on the inside and outside. Those are the collateral ligaments on the sides. Collateral means sides. Ligaments on the inside, those are the cruciate ligaments. We're not going to spend a lot of time again. Those are more trauma issues, and usually a little younger population, but not always. But we're going to deal with the most common thing, which is look at the meniscus. So I want you to look where it is. It's positioned between the top bone and the bottom bone. And this is a bent knee picture. So the knee is now bent to 90, and the kneecap is removed, so it's no longer in our way. A couple things that are very important here. Number one is the surface of the joint is called articular cartilage. Articular cartilage for you, I mean, especially maybe, I don't want to be biased, but women who may bone a chicken, even though men may occasionally bone a chicken too, that's a young chicken. When you bone the leg, that white shiny stuff on the end, that's what's in your knee. When we look at an x-ray, the space between the top bone and the bottom bone, that space is filled with that. It is not seen on x-ray. So when we're seeing arthritis, we're seeing a wearing away or a negative image. We're seeing a narrowing because it's no longer there. Now between the top bone and the bottom bone is the meniscus, and the meniscus is a shock absorber, inside and outside. And we're going to look a little more about the anatomy of the meniscus. This is a pathologic specimen, and the knee really has been disarticulated, which means there's nothing left except we're looking down on the bottom bone, called the tibia. So your knee, the femur's gone, and these are the meniscus here. They're also called the semilunar cartilage. Orthopedic surgeons tend to have names that make sense to them. It looks like half a moon, so we call it the semilunar cartilage. A couple things here that are important. Number one, the bottom bone's relatively flat. This sort of makes it not. See how it comes up a little bit? It's like a wedge. Two is that it's attached on the front, back, and sides. And this attachment, I'll tell you, that's pretty important. You can also see the little fibers within it. Most of the fibers go like that, and I'll discuss that a little bit further also in a second. So what does the meniscus do? The meniscus redirects the forces. So when you're walking, jumping, standing, climbing a stair, all the forces come down from the top. So your body weight and whatever multiple that may be based upon the position your leg is in, it goes into the knee and then is dissipated sideways by the meniscus. Now the meniscus does that by two ways. One is the hoop, the attachments all the way around are like the hoops on a barrel. So if you violate that hoop, all the integrity of the meniscus is gone. All your meniscus could be there. If I cut through your meniscus with a knife or you tear it directly through the rim, you will have no function left of that meniscus. So that's very important. That's seen now more commonly. There's been some recent articles seeing it in the 60s, people in their 60s, and those people go on to have rapid knee arthritis. The secondary function of the meniscus is that it essentially spreads the load. It conforms it. So again, the top bone, the femur, is round. The bottom bone is relatively flat. If you had all your forces coming down and this wasn't there, all the forces, instead of being spread out, would be concentrated in one area. Remember, this area, this surface, is coated with that white shiny stuff on the end of the chicken bone. If you put all the force in one spot, you'll wear it away faster. If you spread out the load, you won't wear it away so fast. So the surface gets overwhelmed when you lose your meniscus, especially when you lose the whole meniscus. The good thing about the meniscus is if you maintain the outer edge, that rim that I showed you here, the hoop, 80% of the functions are maintained. So if you have a normal knee and you tear your meniscus and you don't violate the hoop, 80% of the function of the meniscus remains. You do not get rapid arthritis. If anything, you get very slow onset of arthritis over a long period of time. And that's why the results that Dr. Mirsky was speaking about with meniscus tears alone are very, very good. You just have to select where you are in the picture. Do you have more wear? Do you have less wear? And hopefully you won't violate the hoop, even though we cannot always tell that on MRIs. So why do they tear? Well, God only intended us to live long enough to have children. He didn't care if we limped around after that, because of the pain of bearing children and their teenage years, as well as our aging process. It wasn't that important to him. He was important that we had the children. We've had them now. So this is not a very good material, the meniscus. Why? Well, most of the fibers of the meniscus, and this is again a cross-sectional picture of that semi-lunar piece. So if we took that piece I showed you and we cut it with a knife, we'd see the edge. This is an electron microscope of the same thing. What does it show? Well, all the fibers go in one direction. If you bought really nice, expensive Egyptian cotton sheets, they'd have really a lot of cross fibers. So they would have a lot of ties, and they would be woven very well. And a well-woven rug or a well-woven material doesn't tear. But the one you win when you go on the boardwalk tears on the way home. It tears on the way home because it's cheap and has very little tie fibers. Well, the meniscus doesn't have a lot of tie fibers. That means it's very easy to tear the meniscus with a very simple injury. Matter of fact, 85% of people do not recall an injury tearing their meniscus after the age of 35. If you get up from a bent position, you can do it. If you squat, you can do it. If you have a simple turn or twist. So most people do not recall. Kids require a different type of an injury, and we'll talk about that in a second. So what is it? And Dr. Mirsky showed it. It's really a hangnail of the knee. Top bone, bottom bone. This is the piece of meniscus, and this is a normal surface, nice white shiny surface. And I'll show you some examples of non-shiny surfaces in a second when we get to the arthritic component of that. So what does it do? Why does it hurt? Well, the most interesting thing about meniscus is it has no nerves in it. So if I went in your knee, opened it up, and you couldn't feel that, and I grabbed your meniscus and cut it, you would not feel any pain. If I pulled on it, you would hate it, because all the nerves are attached to the attachment. So when it's abnormally mobile, it tugs on the attachment on the side and gives you pain. And most people have pain in a region of about a silver dollar on the inside or outside of the knee most of the time, with turning, twisting, squatting, bending, mechanical complaints that Dr. Mirsky talked about previously. So meniscus tear is the same as cartilage tear. So when you read the paper, Sports Illustrated, anything you want, these are equivalent. When I talk about articular cartilage, I'm talking about the surface. That's the difference. Okay. So younger patients are usually injured with a trauma, and this is Anthony Davis. He was a running back from Plainfield. I took care of that team at one time. He was a patient of mine, and he was an All-American runner at Wisconsin. So you get hurt with trauma. So you have to have a twisting, an injury. So kids get hurt when they fall down, skiing, football, soccer, something of that nature. Very rarely will a child have a meniscus tear, or a youngster, meaning under college age and below, without having some trauma. There is some subsets that will, but very uncommon. Or they'll fall down and not remember it if they're a college student that's a little older. I have some of those. This is my daughter, younger. She's now 20 and doesn't fall downstairs, thank goodness. She's not like her brothers. Older patients do not need trauma. Most people will get pain with kneeling, squatting, or twisting, or get a tear from that, and most people do not recall that event. So what are the symptoms of it? Well, again, Dr. Mirsky went through some of this, but and I'm going to spend a little more time as we go on separating out when are you a candidate to be treated for this. Clicking, locking, feelings of giving way. The feelings of giving way are because that piece you saw in there is like putting a rubber stop under the wheel. Your knee cannot fully straighten or bend because something's caught between that round surface and the flat surface. Like when I was just coming back from a flight, they put the big rubber stops between the wheels, stop it on both sides, doesn't go anywhere. Same thing happens in your knee. And that symptom, repetitive symptom, drives the treatment. So how do we find out? Well, the sign we do is we twist your leg. We try to duplicate a squat or a turn or a twist, what's called the McMurray sign. This is the McMurray sign. You put your finger on the joint, see if it hurts there, and twist the leg, and see if it hurts. You do the same thing when you get out of a deep squatted chair or a low leather couch. An Apley's test is a similar test, but done with the patient on their belly. So here's the most important thing. So I have a lot of people come to me with just an MRI. That's nice. But we want to decide, are you a candidate to have your meniscus trimmed or not? Arthritic knees almost always have meniscus tears on an MRI. Therefore, a non-arthritic knee, here's an example of a non-arthritic knee, top bone, bottom bone. The space between is the coated surface, like the chicken bone, that has no longer been worn away. These are standing knee x-rays. So when I do it, when I see in the office, I do a standing X-ray, a special bending film which shows milder arthritic change, and I look at the kneecap pictures, which most people will not take, really looking at is there any narrowing. Kneecap X-rays can narrow, and this is an arthritic knee. Once you get past 50% narrowing, the chance of success on a knee arthroscopy drops dramatically. Therefore, I don't really advise most people to do it. There are some reasons to do it. One, you're younger with mechanical symptoms. So you're 50, you have moderate knee arthritis. Every time you turn or twist, it hurts. The chance of success may be 50 or 60%, but that may be good enough for you to buy you some time to get you longer before you need your knee replaced. Okay, so that's really the time when we consider it, or I consider doing it. But I don't like to do it because the results are 50-50 toss-up. So usually with this group, try the injectable treatments Dr. Mersky talked about before. Injectable cortisone, injectable lubricants like Synvisc, water-based physical therapy, swimming, biking, sliding elliptical are all the best treatments without overstressing the knee. But the most important decision, and that's the gray zone that almost everyone in this room will be in, will be, do you have this? Do you have that? Or do you have something in the middle? That's when it gets harder. That's why it's more an educational process. What are your odds of success? What's the chances of it working? Is it reasonable for you? How long have you had it? What else have you tried? You know, these are all the little issues that come into play. And most of it for me is an understanding that you need to know that I can't make you perfect long term if you have mild arthritis. I can make you better, which is what we're doing with everything if you have some mild arthritis. We're trying to make your knee last longer and make you have less symptoms to do the things you want as long as we can without giving you a new knee, if we can do that. If it doesn't work, then the new knees work well. But I prefer you had your own as long as you can. And I'll talk a little bit about the age process and my logic on some of that in a second. So how do we make our diagnosis? And the young man over here had a question about when's an X-ray important, when's an MRI important. Well, the X-ray is very important. If you had the X-ray on the left and you came to see me, I'd never order an MRI. It's a waste of money. I already know your problem. I know you're not a candidate for arthroscopy with that picture, and so I'm not ordering an MRI, unless I'm worried about something unusual. The MRI is accurate in the diagnosis of meniscus tear, but the grand majority of people with knee arthritis and a large percentage of people over the age of 65 have MRI findings of meniscal tear or false positive findings, meaning it's not really there. So in that circumstance, you've got to keep that in mind. So the older you get, the less reliable the MRI is to diagnose it. But it does help us to diagnose what you don't have. There's some things you can have that will mimic the symptoms that will never get better surgically and can be treated in different ways. So we do it occasionally for that. It's not just for this. So you're now a candidate for arthroscopy. We've gotten through that already, or you've decided you're a candidate. So how can we treat it? If you look at the internet, everyone's saying, I want my meniscus repaired. That's nice. I really can repair any meniscus. But it only works if it's in the vascular zone. This is a cut through a knee after it's been injected with dye. This through the blood supply. This is the blood supply. This is no blood supply. Top bone, bottom bone, that's that wedge we talked about again that's causing the conformity. You can see that again, round and flat. If you tear it here, and I repair it, it will never work. It's almost like sewing if you cut your nail in two, the edge of your nail that's sticking out, and most men trim theirs a little bit tighter than women, but if you cut it and you sew it together, it'll never work. You'll need to trim with a nail clipper ultimately because it has no capacity to heal. It only has capacity to heal if it's here. And young kids, 20% of the time tear it here, and we, in general, tear it here, occasionally here. I've repaired people's meniscus in their early 50s when they've torn their ACL skiing, they had a trauma, they torn it here. The results are no different if you're older, it just doesn't happen very commonly. So that's the reason. So it's really more about success. I like for the surgeries to work. I prefer to do one. I don't need any annuity process where we need to do multiples. So I'd like to give you the best odds of success with one surgical treatment. And that's why, for me, I would not repair this area. Typically, again, 16-year-olds, I push all the limits and I repair. If you're on the edge, you're getting repaired. Because it's worth your 16-year-old to have as much cushioning as long as they can. And it's worth the risk of failure of about 20% or so to do that. It's not worth it if you're 50 and working and the odds of success are low, and you're limited significantly post-op by that. So when do we fix this? This is a meniscal repair. Meniscal repairs are done. This is an arthroscopic picture. Top bone, bottom bone, meniscus is here. That's the red. See how nice and red it is? That's the vascular zone. That's where we can fix it. You have to have an intact body. This has to be in good condition. If there's a cut like that, that won't work. And even though I'll take people that are young that have a cut like this, I'll trim it back so it's smooth, and then I'll repair the edge because I want to get that rim to be returned back to normal. But that's very uncommon tear type for young people. And it has to have a stable knee. Repairing a meniscus with an abnormal ACL or an unstable knee will not work. This is the types of meniscal repair. We have new techniques now. We used to use an arrow, and if anybody in here had a meniscal repair in the past, these are plastic, semi-absorbable. They cause some problems because the heads would rub against the top and give you arthritis, and I've seen people have troughs in their bone carved in by that. I never liked it or used it. I always used either sutures, but now we have a new technique where we poke, there's a little stopper, you can self-ties itself, really relatively easy to do and safe, and that works pretty well. I've been using that now for probably 3 or 4 years, and I like that. Again, more in conjunction. This is a picture of a meniscal repair in the old days with sutures, tying it together. 70% success rate without an ACL tear, 90% in the face of ACL tears, and that's when most of them are repaired, because most of the time that injury is significant and tends to tear peripheral tears in general. So when do we do it? Well, we do it, hopefully people are coming to see me have symptoms, because if they don't, they probably don't need to come in and wait in my office for me. But some do, not many. So we need a symptomatic mobile meniscus tear. So if you have an MRI that shows a tear and you have no pain, you do not need me. Can't make you better than no pain. There are people like that. I also think there's some people that MRIs are wrong. If it's more likely the MRI is wrong than it's asymptomatic, or it's very early and it becomes symptomatic later. We always treat symptoms. We don't treat MRIs, and so we really want to get the diagnosis. But if you don't have enough symptoms, you don't need anything. So having had 3 arthroscopies on 2 knees, so it's divided up, I could tell you that for the most part they work very well for the mechanical symptoms. They don't work very well for arthritic complaints. This is mostly in adults again. Kids usually have them with big injuries, and usually they have a higher chance of repair. This is a knee arthroscopy Dr. Mersky talked about. Outpatient, I had one about 8 weeks ago. 2 small cuts in the knee. Camera through one, inflating the joint with fluid, and then working through the other with almost a fancy nail clipper on a stalk, essentially. Sucking the pieces out with a little suction and a shaver to smooth it. What we want to do is make sure there's no edge. The way we trim it is if your tear's like that, we taper it so there's nothing to catch and cause a new tear, because again, the material's not great. So we don't want to have you have one tear, then get another tear. Re-tears are not so common, but they occasionally happen. Because we leave, why? We leave as much as we can leave. You want to have as much shock absorption as you can. It's worth the risk of possibly tearing it again, because that means you have enough to tear. But it's not so common once you've trimmed out because most people lose the inner third or half. This is the one that's not amenable to repair ever. See how beat up it is? It looks beat up. It doesn't look like it's very good material. It's all sort of, this is a degenerative meniscus tear. This is the most common thing that I treat as far as meniscus, and this is very well suited to arthroscopy. And if you look at the top again, nice shiny white material. Nice shiny white material. This is a non-arthritic knee with a meniscus tear. They do very well with treatment with arthroscopy. And again, we contour the rim. We preserve the rim. We want to make sure the barrel hoop is intact, so we're really not taking out too much. We always take out as little as we can and contour it. What are the results? Well, here's again, this is all about selection. Who needs the operation? Who doesn't need the operation? If someone tells you you need a knee arthroscopy and they have not done standing knee x-rays, they can't gauge your success rate. You need good standing knee x-rays. So what does that mean? If you have no arthritis at all, then your success rate at 12 years is 95%. And really quick rehab. I had mine on Friday. I was at work on Monday. Dressing off the next day, ice, shower, get the wounds wet, bending, straightening, walking. Occasionally people need therapy. Most people are pretty mobile pretty quick. You don't feel normal in 3 days. I didn't feel normal. I felt like I sprained my knee and it was getting better. And typically over about a 6-week period you get better and better. And your limitation is how much arthritis do you have. If you have some mild arthritis, you can have persistent mild symptoms. If you do, they can be treated with the injections again. Once you've had your meniscus trimmed, we now know the only problem you have left, and that's the wear. The x-rays give us a guide on what your odds of success are. If you were going to Atlantic City, and I am not a gambler, and someone told you have a 95% chance of winning, most people would bet. If it's 50-50, they'd think about betting. If it's 10% at a year and you need another operation, most people aren't betting. So it's sort of a gauge of where are you. And if you do all the good standing films, which I think are the most important part of the evaluation for knee pain, then you can define where do you stand in the gray zone. And then be educated about what your chance of success is. And hopefully you're on the good end. I tell people in the office, if it's 80% success, 20% of people aren't better. I don't know who they are. If I knew who they were, I would tell you not to have it. I'd like to have happy people that are better. I don't know who that 20% is. I'd like not to operate on them. The problem is we don't have any way of telling that with what we have today. And so our success again dictated by that. Very simple if there's no arthritis. It's a no-brainer. It works quite well. Causes of failure. We talked a little bit about that for people, osteoarthritis. And everyone has a little. You know, I mean, I go in people's knees. I have 80-year-old patients I do arthroscopies on, no arthritis. Good genes. I have 50. I'm 52. I have knee arthritis. My mother had bad knees. I have bad knees. I'm going to have worse knees. I'll need my knees replaced one day. Genetics are very powerful. Injuries are very powerful. Had those too. So the combination can make your knees wear out faster. And that won't. Knee arthroscopy only works if you have a little of that. And in kids, especially young ladies, they get kneecap pain after knee arthroscopy. We really don't know why that is. It's very, very common for young girls to have pain in the front of their knees with stair climbing, sitting. In general, number one diagnosis for a young lady without trauma, teenager. So they get some of it post-op sometimes. Usually treated with therapy. So here again, results. I know I'm harping on the same thing. This is the gray area that Dr. Mirsky was looking mostly at arthritis. I'm looking at where do we go. No arthritis, very good. All back one. All back one means on an x-ray, standing, 50% joint space narrowing, 65% are better at 3 years. And that's a very optimistic study. I picked the best study. You know, most people, anybody worse than that, bad. Doesn't work. You're better off having shots. The success rate of shots is better than the success rate of arthroscopy there, most people, again. And this is what we're looking at. Normal knee, nice white surface like the chicken bone. Arthritic knee, no surface left. If you took your chicken bone at home and scraped the heck out of it with a fork, that's what arthritis looks like to me. So that gives you sort of a good view of, and feel the smoothness of it. It's very, very low friction. It's like a Teflon coating. Once you wear it, it's rough. And anyone here that's old enough to have worked on cars, my father was a mechanic, the bearings start to squeak, the bearings aren't working, they eventually cinch up and they fail. And that's what's happening. This is a bearing surface that's failing. And a lot of variables. It's not just weight. It's mostly, in my view, genetics, number one. Number two is trauma. And number three is just how heavy you are makes how symptomatic you are with the same knee arthritis. I have plenty of thin people with really bad knee arthritis that have never had a trauma. But their families, every one of them has a knee replacement. So a lot of it is genetic. So I don't like to blame weight, but then again, you know, I mean, I'm not Dr. Mirsky, so I don't get to we don't talk about weight in my office too much. Here's our x-rays again that I showed you before. Standing knee x-rays, number one most important thing. MRI alone is not enough. Thank you, guys.